Hello, my name is Bhanu Pinnam. I'm currently a third-year internal medicine resident physician at Cook County Health in Chicago. I'm excited to discuss our study, a comparison of endoscopic and surgical gastrojejunostomy in patients with malignant gastric outlet obstruction, a national cohort analysis 2016 to 2020, published in GIE Journal. I would like to thank all my co-authors for contributing to this study and GIE Journal for giving me this opportunity to discuss it. I will provide an overview of our findings, their clinical implications, and future research directions. Malignant gastric outlet obstruction is a severe complication that arises in patients with advanced upper GI malignancies, including gastric, pancreatic, and duodenal cancers. Historically, surgical GJ has been the standard of care for palliative treatment, providing a bypass route to restore gastrointestinal continuity. However, in recent years, endoscopic GJ has emerged as a less invasive alternative, particularly with the advent of lumen-opposing metal stents, or LAMs. Despite its increasing adoption, there has been a lack of large-scale data comparing the two approaches in terms of outcomes and healthcare resource utilization. We aim to compare peri-procedural outcomes, hospitalization metrics like length of hospital stay and hospitalization charges, and adverse event rates between endoscopic and surgical gastrojejunostomy. To achieve this, we analyzed data from the NIS, or National Inpatient Sample Database, from the years 2016 through 2020. We identified over 20,000 hospitalizations with malignant gastric outlet obstruction undergoing GJ. Patients were then divided into two cohorts, those undergoing surgical GJ and those undergoing endoscopic GJ. The surgical cohort had 16,585 patients, while the endoscopic cohort had 4,345 patients. A multivariate regression analysis was performed to adjust for confounders when comparing outcomes between the two cohorts. In our study, it was striking that while the overall inpatient mortality between the two groups was not significantly different, endoscopic GJ was associated with several advantages. Number one, there was a lower rate of peri-procedural adverse events. Endoscopic GJ was linked to significantly lower odds of peritonitis, sepsis, septic shock, respiratory failure peri-procedurally, and peri-procedural need for blood transfusion. Surgical site infection occurred in 3% of those undergoing surgical GJ, while for obvious reasons this was not a concern in the endoscopic GJ cohort. These findings suggest that endoscopic GJ may offer a safer peri-procedural profile compared to surgical GJ. Comparing healthcare resources utilization between the two groups, we found that patients undergoing endoscopic GJ had shorter hospital stays with a mean difference of approximately 2.24 days compared to surgical GJ. The endoscopic GJ group also had lower hospitalization charges, reducing costs by an average of $16,495 per admission. We also assessed trends in the GJ use over the study period and observed a notable increase in the use of endoscopic GJ over the 5-year study period from 16.8% of malignant gastric outlet obstruction undergoing endoscopic GJ in 2016 to 24% in 2020, reflecting growing confidence and increasing availability of endoscopic techniques. These findings have important implications for the management of malignant gastric outlet obstruction. The reduced length of stay and lower rates of complications suggest that endoscopic GJ could be a preferred option in appropriately selected patients, particularly those who are high-risk surgical candidates. Given its minimally invasive nature, endoscopic GJ may provide a better quality of life with fewer post-procedure complications, which is an important consideration as GJ often tends to be a palliative measure where comfort is valued. However, it is important to note that successful endoscopic GJ requires specialized expertise in EUS guided procedures, and accessibility to LAMS technology may not be uniform across all institutions. As such, patient selection and institutional resources must be carefully considered when deciding between surgical and endoscopic approaches. While our study provides valuable insights, it is not without limitations. The retrospective nature of the NIS database means we were unable to capture long-term outcomes such as stent patency and delayed complications or reintervention rates. Additionally, procedural details such as specific techniques used for endoscopic GJ were not available in the dataset. We believe that future prospective studies and randomized controlled trials are needed to further validate our findings and refine patient selection criteria. Additionally, research into optimizing endoscopic GJ techniques, including advancements in stent technology and procedural standardization, will be crucial in further improving outcomes. To conclude, our study suggests that endoscopic gastrojejunostomy is a promising alternative to surgical gastrojejunostomy for malignant gastric outlet obstruction. With lower peri-procedural adverse event rates, reduced hospital stays, and lower healthcare costs, endoscopic GJ may be an optimal choice for many patients when expertise and resources are available. We hope our findings contribute to the evolving landscape of endoscopic interventions and encourage further research in this space. Thank you for your time, and I appreciate the opportunity to discuss our work.